think we're going to make a bit of a transition here for Dr. Chemtob, who I'm hoping is not in the back of the room finishing his presentation, but I think he is done. I want to tell you a brief story that I have as he comes up and we set up his video. We are, UC Davis, part of the National Child Traumatic Stress Network, NCTSN, funded by SAMHSA. And the purpose of it is to increase awareness and training and skill for mental health providers who deal with traumatized children. And all of you are familiar with the PCIT web course. That was funded by the National Child Traumatic Stress Network to put it together for the purpose that it does, so that you can train other people in your agency. The network also has annual conferences. And I was in Baltimore, gosh, probably about 5, 6, 7 years ago. And in Baltimore, I was listening to somebody talk and had this tap on my shoulder from this man who said, "Are you Dr. Well, wait a minute." He said, "Are you Dr. Urquiza?" You'll notice Dr. Chemtob has a rather deep voice, deeper than mine, and I want to be on record here that his voice is deeper than mine. And he said, "Are you Dr. Urquiza?" And I said, "Of course." And he said, "I need to talk to you." And at the same time, Susan Timmer and I had been struggling with this population of families that were really, really difficult to see. These were severely traumatized mothers, often who had serious problems with depression. And you know those families because you see them every day. They're the ones who I think have the most difficulty participating in PCIT because of their problems with trauma and because of their problems with depression. And what I didn't know at the time was Dr. Chemtob, who is involved in treating traumatized women, traumatized mothers, was also struggling in a completely complementary way. He was struggling because these women that he was treating and had developed this treatment program for, severely traumatized women with depression, had children who were, of course, you know this description, defiant, temper tantrums, aggressive, biting, hitting, kicking, screaming, all of those guys that you see on a regular basis. He was the complement. He had these mothers, we had these kids. We were struggling with trying to help these mothers. He was struggling with trying to help these kids. And he said to me, "Are you Dr. Kiza? I need to talk to you." And it started a relationship that is a wonderful relationship because these two interventions are really good, complementary in fulfilling the mission of helping children and families at risk. And so, as he casually walks up to the screen, and we set up for him, I would like to introduce Dr. Claude Chemtob from New York University. He's a research professor at New York University, and I think you're going to set up his program.
That's true.
Okay, now you're all set. So, after that wonderful introduction, I'd like to introduce Dr. Claude Chemtob, New York University, who's going to talk about safe mothers and safe children.
Thank you.
Thank you very much. It's a privilege. Now, before we go on to serious things, who sings I Have a Deeper Voice and who sings Dr. Urquiza has a deeper voice? Urquiza? Oh, man, you win again. I keep claiming, I'm sorry, I keep claiming otherwise, but I guess I'm not going to get away with it. Look, it's a real privilege to be with you because I'm a newcomer to PCIT, and in fact, Dr. Urquiza and Timmer have been really my teachers, like I think for many of you. And so it's a privilege to be with you all because I think there's something very powerful about the work you do because it really affirms the connection between parent and child. And as Dr. Belshi said earlier, there's been a real neglect of parents in our work, and particularly in child welfare. And I'll come back to that. This is really eye candy to help wake you up. And then what I'm going to talk about today is this notion that in order for children to feel safe, mothers have to feel safe. And I'll talk a little bit about the cost of seeing mothers, fathers as perpetrators, even when they are, and what it does to our sense of relationship and our capacity to build a treatment alliance. And my focus is really going to be on the notion that if we recognize that when mothers don't feel safe, when they themselves have been traumatized, when they've been abused, that this, in effect, means that they have disturbances in their capacity to feel safe, which means that the relationship between mother and child is in of itself a less than ideally stable one. And so I think we have to really focus over and over ourselves on the relationship. It's very easy to make a shift, even for people like yourselves who are specialists. And when that happens, I think it interferes significantly with the treatment alliance and our capacity to get the best results. My primary focus is going to be on repeat maltreatment and on the development of an emerging therapy that we call parenting STARE that's intended to address parental PTSD and depression as a means of improving the relationship between parent and child and ultimately preventing repeat maltreatment. I'll describe for you some open trial results, and hopefully we'll have some discussion about the implications for practice. So let me say something about this kind of work. You never do it alone, and there are a number of people at NYU who have collaborated, a number of people at the Administration for Children's Services, who have collaborated as well, and that's New York City's public child welfare system. We benefit from a structured relationship in which we're trying to bring to bear knowledge about trauma in order to improve child welfare outcomes. May I ask how many of you routinely work with families that are in child welfare? The very large majority. So, from UC Davis, and Dr. Anthony Urquiza, Dr. Susan Timmer, and Diana Boyes have been very helpful. And from the National Center for PTSD in Palo Alto, my colleague Marilyn Cloyder. And we've had the good fortune of receiving funding when I would not have refunded us. So our funders had more belief in us than sometimes we had. Now, I'm a little bit different than most of you because I come to this field of child welfare as somebody who's really known as a terrorism and disaster expert. And I began to be very interested in preschool children after 9/11, when I had a fairly leading role in the recovery in New York. We worked with a lot of preschool children who were living downtown, very close to 9/11. And these children were between 2 and 5 typically, and had seen people jumping out of the building, injured people, towers collapse, and so on. And we were interested in the idea that children have two impacts when they're exposed to terrorism. The direct thing that they see, although most people don't really accept that preschool children are affected directly. They say, oh, they're too young. People like you, of course, understand that that's nonsense. So we were interested in the direct effect and also the indirect effect via the impact of being on 9/11 on mothers. And one of the things that's very nice in a disaster is you're really dealing with a normative population. And by virtue of where this happened in New York, you had a range of very high income people and relatively low income people. And there was a sense that anybody could be affected by trauma. With child welfare, we're always fighting the sense that it's those people and not me. Another problem in this notion of what's an alliance about. So what this slide shows you is that we found that if children had had prior traumatic events and were exposed to 9/11, the slide on the right here shows you how much more likely they were to have clinically significant problems on the CBCL. And you can see that if they'd had a prior trauma, it whammied up their likelihood of being affected adversely. Then we were very interested in this notion of how much does the mother's impact and secondarily the relative impact of PTSD and depression, because we've known for a long time that maternal depression affects children, but there's been very little research until recently on how maternal PTSD affects children. And most of the depression research did not assess for whether the mothers had comorbid PTSD along with the depression, even though these things run together all the time. So one of the things we looked at here is what's the relative impact of the child's exposure to trauma, maternal depression, and maternal PTSD. And you can see that maternal PTSD, these big numbers, had a much larger impact on children having clinically significant problems than maternal depression. So that was of interest to us. And interestingly, maternal trauma and symptoms was much more substantially impactful to the kid than direct exposure. So we also looked at, in a laboratory, we looked at how mothers and children interacted, and we found that mothers who had PTSD were much more likely to be intrusive and much less likely to be responsive to the kids and had less positive affect. Now, moving along, we replicated the study with, could I get some water, Anthony? We replicated the study with a very large sample in Israel that lived in a community called Sderot, very close to Gaza, and had recurrent rockets that hit them. And again, what we found is that maternal PTSD had a huge impact compared to depression, and that it was particularly maternal arousal. So when a mother has PTSD, there's a dysregulation of her ability to calm herself, and thank you so much. And that dysregulation, the arousal component, was very significant in whether kids had problems or not. So that intrigued me. Now, as part of, one of the challenges in doing child welfare work is having fathers involved. As you know, they don't show up too often, right? Is that your experience as well? Right. So we tend to say it's the mothers, but what we in our study in Israel, about 1/3 of the fathers did participate, and we're just looking at the fathers. What we discovered is that paternal PTSD was way more toxic for kids in terms of their clinical problems. And, I skipped one. I don't think I have it here, but some of you will not be surprised that if a father had PTSD, not only was it toxic for the kid, but it increased the probability very substantially that the mother would have depression. Of course, that makes sense because she's taking care of the kids and protecting them while trying to take care of the father. So part of the reason I mention that is we tend to focus on mothers And even they are difficult to get in, but we have to keep fathers in the background. Now, one of the things that happened after 9/11 is that the child welfare people came to me and wanted me to do some teaching. I said, okay, you know what, I'll do some teaching, but then you have to teach me about child welfare. And my notion was that terrorism and disaster are collective trauma. I think I'm going to have to go much faster. And that child trauma, an individual abused kid, is having an individual event, which is very much a disaster for that child. And I began to learn quite a lot about child welfare. And some of this stuff I can go very quickly with because you all know much about it. Thank you so much. So we know that child maltreatment has many, many adverse consequences ranging from social to increased juvenile incarceration, to increased suicide, to increased health problems. And one of the really, really important things to keep in mind is that when children are exposed to multiple adverse childhood events, ACEs, when they have multiple events, it increases very substantially the likelihood of adverse outcomes. Now, unfortunately, when we look at the notion of preventing child abuse, repeat child abuse, and we really look at what the evidence shows, we see that parent training programs are used quite a lot, which is not to say that they don't help. There's certainly some evidence that they can help, but the evidence is very weak that they prevent repeat maltreatment. And as you know, that's really essentially the target, and that's a money shot, if you will. Same thing is true with home visitation programs. And they've become very popular because of the good work of Dr. Olds, but they're actually much more, how shall I put it, controversy about their efficacy. And we know that they're effective at preventing initial maltreatment, but they do not appear to be effective at preventing repeat maltreatment. And one thing to keep in mind is that there is emerging literature, including from home visitation people, that mental health problems are a substantial barrier to effectiveness. So, you know, I looked for things that worked, and I discovered that there's a fellow who is now a collaborator, Mark Chaffin, who, drawing on a rationale first articulated by Dr. Urquiza and one of his students, conducted a randomized controlled trial to examine PCIT's effectiveness or efficacy in reducing repeat maltreatment. And he found that if you combine motivational interviewing, a way to increase the commitment and the interest in the treatment, with PCIT, you got some pretty good results. So 19% of the clients who were receiving motivational interviewing and PCIT versus 49% in the randomized condition. Oddly though, motivational intervention, he did a second study, which was a larger dismantling study, and he found, again, MI plus PCIT, a pretty good result. It had 29% recidivism compared to 37.5 for the control condition. What was weird, though, is PCIT without the motivational intervention had the highest recidivism rate of 47%. I would also point out to you that 29% ain't too great, right? That means 1 in 3 people was repeating maltreatment, and often more than once, right? There's also a study of safe care that seemed to show reduced recidivism, 19% compared to 45%. But then what happened is that in the next study, and it often happens, unfortunately, in these efficacy research, some of that effect disappeared. And they really did not have significant effects. And in fact, one of the things that study showed us is that if the participants had mental health problems, they were much more likely not to be responsive to treatment. Now, one of the questions for me was, could treating trauma-related disorders reduce maltreatment? And this was a question that we batted around together with the folks in New York. And we did a study which in the context of preventive services. I don't know what you call it in California. In New York, preventive services are sort of social support services that are provided to families where abuse has been identified, but it's not so severe that you have to remove the kid right away. Right? In that difficult tension between maintaining the integrity of a family versus protecting a child, and there's an investment of resources. So we did a study of preventive services agencies, and we talked to them, and then we did a screening of about 200 of them, of the cases, and I had expected that we would have very high rates of PTSD, being a kind of a PTSD imperialist, right? And thinking there's much more trauma impact than we recognize, especially in poor populations. So what would you guys guess was the rate of PTSD in this population? Fairly poor inner city population. Some guesses? I had expected 20%. 5-6% is the population rate across the US population, 7% perhaps. Anybody have a guess? 80%. Well, in some populations, I think that's true. In that group, what we discovered is that about half of the population had comorbid PTSD and depression. Okay? And we've learned, I didn't mention it, but we've learned from our research with disaster, but also other traditional research, that when you have comorbid PTSD and depression, things are way worse. It's not 1 + 1, it's 1 + 1 is 4, right? And half of them, and nearly 60-70%, met criteria consistent with PTSD. Now, it was a screening study. So that really interested us because it told us that this was a group that really had high rates of PTSD. So we started to look as to what extent is trauma associated with risk for maltreatment. And we just looked at maternal history of child maltreatment, and we found, as you can see, that being maltreated as a child is associated with lower parenting competence, less pleasure in the kid, more physical punishment, and that women who are exposed to child maltreatment are at far greater risk of being in domestic violence relationships. And in being in domestic violence relationship, controlling for depression and stress doubles the risk of being re-reported. Repeat again, right? So we looked at PTSD because being exposed to child maltreatment doesn't mean you have a disorder. And clearly, we found that I mentioned to you that, I mentioned to you these results. If you're interested, they were published in 2011 in Child Welfare. And we found that PTSD is associated with insensitive and hostile parent-child interaction, disciplinary tactics characterized by hostility and greater physical aggression, that maternal PTSD predicts a kid's inability to regulate themselves. So self-regulation is something you learn as part of learning to keep yourself feeling safe and maintaining well-being. And obviously, besides preventing abuse, we want to increase well-being. So the thing we also found out in another study is that the kids of mothers who had PTSD or had PTSD and depression were much more likely to have more traumatic events in their lives. So if you had PTSD alone, your kid had on the average 5 traumatic events by the age of 5. If you had depression and PTSD, it was about 4.25 or something. If you had neither, it's under 1. If you had depression alone, under 1, or right around 1. Okay? So not only are these children exposed to their mother's difficulties and their consequences on parenting, but they're also not protected from as many environmental events. So in a sense, they're living in a more dangerous world and experiencing less ability to manage their toxic stress. Right? So I probably don't need to tell you all that maternal depression has also been shown as a recidivism factor, right? Depressed parents are 3 times more likely to report that they physically abuse their kids. Depressed mothers have more negative interactions and fewer positive interactions. Now, the Davis group has shown, as has another group, that depression doesn't necessarily interfere with PCIT effectiveness. But to my knowledge, there's been no corresponding study focused on PTSD. So we began to think that since many symptoms associated with PTSD and with depression manifest as harsh parenting, poor emotional regulation, and a reduced investment in the well-being of one's children, there might be some value in thinking about targeting what we call trauma-related disorders. So let me sort of give you some sort of more clinically accessible notions of what I'm talking about. As all of you, I'm sure, know, one of the key symptoms associated with arousal in PTSD is that people get more irritable. It takes less to get them irritated, and they get harsher and more likely. They have a lower threshold for both anger and aggression, right? So think about that in the context of parenting. What does that look like if you don't know that the person has PTSD? Just like they're bad people, right? If you, on the other hand, appreciate that the perpetrator is also a victim, it may give you a different perspective and potentially a portal for entry for treatment. Same thing with traumatic reminders. If you have PTSD, something that reminds you of the trauma will set you off emotionally, will get you all dysregulated, and it will impact not only you, but the people around you. What did we find as we were working with these women? That very frequently they would have a child, perhaps a boy, who was the son of their violent partner, who looked like the partner, and seeing the boy, rather than inspiring protection, would inspire traumatic reminders, and they would shun the boy and feel a great deal of conflict. And a lot of this stuff doesn't happen at the neocortex level, right? Especially if you're tired, if you're poor, and you have too many kids, right? Especially if you have a new partner, because a lot of the women we work with have multiple fathers with their children, and you're trying to deal with that. But so the point I'm trying to make is that these symptoms we look at in PTSD, for example, we don't often think about how do they impair one of the most important life domains of functioning, which is parenting. Same thing with emotional regulation. Think about it. If you're feeling easily disturbed by reminders, if your ability to manage your arousal is reduced because of PTSD, and your kid is making your life a little bit more miserable than normal, most parents over time will manage that with some slippage. But it's much more likely that if you have PTSD, which is characterized by poor emotional regulation, that you'll have more difficulty staying calm when your child misbehaves, more difficulty coming up with essentially a balanced response that has some poise, more difficulty establishing boundaries. And what we see often in these folks, these mothers with PTSD, is that they will report alternating between being irritable and angry and withdrawn and unavailable, which of course certainly does not cast a context of safety for the child, right? I mean, if you don't know what your mother's going to do, she's going to yell at me, she's going to ignore me, that's sort of a, you're constantly trying to figure out what things are. And what I say in the context of disaster is that the way young children know they're safe, and we learned this in disaster very well, is they basically look to see how is mom responding. Because mom is not a good bellwether of things, that creates, in effect, what do you call that? A swamp underneath their feet, right? It's not a context that supports optimum development. Some of the other things associated with PTSD is that people tend to focus on the negative. They're always looking for danger. So they increase their kids' anxiety, and they also they look for the worst in their kids. Very often these mothers say to us, my child did this to upset me, right? So these attributions are highly negative. This is not new to you all. You hear these things, you get shocked by them, I'm sure sometimes, because it's sort of not sensible until you really appreciate the depths to which the capacity of these mothers to feel safe is compromised. You with me? You agree? Okay. So we decided then that that it would be useful to develop a treatment, and we had also some other reasons to think about it. We know that PTSD patients, like depression patients, have impaired reward processing. So a smiling child is not as likely to make them feel good as if they didn't have PTSD. That makes a child feel more helpless, and there is a lack of pleasure, which is really part of what protects a parent-child relationship. In addition, many of these moms who were traumatized as kids grew up in an environment in which they didn't get to model, watch, or experience what good parenting feels like. They're missing skill development, right? I mean, they just didn't see it. And in addition to that, if you're really psychologically dysregulated, that in itself gets in the way of learning things as you grow up about how to parent. So the additional piece, and my view is that this is really the money shot. And I think it was our colleague earlier who pointed out the importance of parents. The money shot for me is the interaction of trauma and poverty. Because people who are poor are stretched thin and have a greater, opportunity to be traumatized, if you will. And so at that point, you begin to see these intergenerational effects. You begin to see a kind of eating one's own young, in a sense, because you're in such an adaptive, strained environment. And I think it makes adaptation much more difficult when you don't have resources. So we focused on developing parenting STAIR, and we did it in collaboration with preventive service. I mention it because how you develop a treatment is an important question these days. Most treatments, most mental health treatments that have been developed and that are used in child welfare were not developed in the child welfare context. So they're always being adapted. The research we rely on tends to be not from child welfare samples. And so we wanted to approach this a little bit differently. And we did it by collaborating on one hand with the public welfare system, and probably just as in LA, because I think it's true of large systems in general, most services nowadays are provided through contracts. So we also collaborated with clients and service agencies in trying to figure out how to make these ideas about trauma accessible and useful. And we developed a multi-pronged view of what treatment should be about. So most people who are mental health people think mostly in terms of sitting in an office and seeing somebody. And I personally have a problem with that. And I say I have a problem with that because my analogy is, what if the white cells in your immune system sat in their office waiting for the microbes? Right? So I take a position that we have to assertively reach out and identify cases. In fact, what we know from extensive research, including our research, is that left to their own devices, even good mental health therapists who have been trained miss almost all trauma and PTSD. I call it the don't ask, don't tell principle of trauma. You know, we don't want to know, they don't want to tell. And so you see amazing stuff where in one agency that we studied, it's 200 people, only one case had a PTSD, diagnosis. In a city, highly traumatized group, one case was PTSD. Look, we know that even in a normative population, it should be 7%, should have been 14 people. So that's like weird, right? When you see less than what's supposed to be there, not only don't see what's there. So one of the things we did is we developed a relationship with a number of these agencies in which we taught their case planners how to screen for PTSD and depression and domestic violence systematically. And initially they were quite worried about it, but they discovered nobody's upset about it. In fact, people on both sides found it helpful in our research. Then we also trained the case planners on how to work with traumatized people. It's very hard for us, even those of us who have had a hard time, to really get the level of sensitivity to trauma that our populations really experience. And one of the challenges when you work with a traumatized population is that what do? Again, they avoid. So when you say, hey, let me help you, they go, yes, thank you. And then you can't find them again, right? And you think, oh my God, I'm doing really good for you. What are you doing? You're like busting my angel fantasies, right? And it's a bit of a challenge because, you know, I'm a little bit crazy and get into weird stuff. I'm known, one of the things I'm known for is the treatment of very angry Vietnam veterans with PTSD. Well, what do they do when you try to treat them? They get angry at you, and then they fire you, right? So the problem with PTSD is that it's hard to make an alliance. So the other thing we did, in order to deal with this problem of making an alliance, we figured that these women, these families were already going to these agencies, they had relationships there, so we put our therapists there instead of making them go somewhere. As many of you know, you get about 20% of the referrals that are made to you to show up, right? And then keeping them is another story. So, and then we redefined confidentiality, and we made it clear to those folks that we would be talking to their case planner, and the three of us would be talking. And we're more assertive than many in that our treatment providers actually will attend high-risk and elevated risk conferences. And what we've seen over and over again is that these women in these elevated risk conferences are feeling so attacked, so vulnerable. Remember, they're not good at maintaining safety and easily feel attacked, right? That they can go off when people really mean well, and we can interrupt that because of the alliance with the therapist. And then we provide ongoing, ongoing technical assistance. Now let me tell you about our treatment a little bit. Our treatment is, we call it parenting STAIR. STAIR comes from a treatment developed by Marilyn Cloyder called Skills Training in Effective and Interpersonal Regulation. My good friend Marilyn had this insight that I agree with, which is that a lot of folks who have had child maltreatment don't have good enough distress tolerance to maintain an alliance with somebody when we do traditional trauma treatments such as prolonged exposure. It's too much for them, and they basically book. And you see that over and over again. So her idea was, let me teach these folks how to identify emotion, how to regulate emotion, how to tolerate distress, how to maintain a relationship as a first phase of treatment, right? And the second phase of treatment is a modified trauma processing approach. So we adapted that because it made sense, and the Treatment Alliance, by the way, we've published some papers on this together, predicts success. So the ability to teach somebody to feel like they're aligning with you and they're safe with you predicts whether treatment will be effective or not. And we looked for a treatment, so that was a regulation skill, right? And we wanted something based on the idea that these women do not know how to parent, that was a structured approach to teach parents how to parent, parenting skills. And to us, PCIT seemed a very good approach. And we wanted to save some time by not reinventing the wheel, but by putting together evidence-based components. And we're very lucky because Drs. Timmer and Urquiza helped us with that component. And in effect, what we did is we took STAIR, Skills Training in Effective and Interpersonal Regulation, and focused it on how the PTSD symptoms affect the women's parenting. We quite explicitly do not expect that the women will necessarily be better. Our focus is changing, ameliorating, reducing the impairment in parenting. Remember, what we want to do is change the relationship so it doesn't stray again into repeat maltreatment. And we figure, hey, we can refer people to therapy if they need more of it. And so we adapted STARE to focus on parenting, a trauma treatment focused on parenting, and conversely, recognizing that trauma symptoms can get in the way of learning parenting skills, we integrated an understanding that learning PCIT skills can be interfered with because of emotional dysregulation, because of intrusive thoughts, because of hypersensitivity to irritability, and so on. So we integrated to some extent trauma into PCIT. Our treatment then is a three-phase treatment. We teach effective and interpersonal regulation skills, focusing on parenting. We then process the trauma, always looking to see how it became ingrained in the relationship to the kid. And then our third phase is actually a dyadic phase in which the parent is coached in integrating those things that they're learning in actual interaction with the kid. I'm not going to go too far into this except to say, because of time, that it's really a skills-based approach. One thing you should know, though, is from the beginning, because we believe these mothers are not good at seeing the good in their kids, we really drill them and give them homework in which they come back telling us something they saw their kid do right. I remember one of my teachers telling me, any idiot can find something wrong with somebody. It takes more intelligence to identify something right with somebody. And if you're consistently stressed, negative, reactive, dysregulated, it's even easier to find something negative because it's all annoying, right? It's more failure. And so I didn't have a chance to put it up on the website, but I will for you, for those of you who want to see these details. So our specific treatment goals for our treatment, first and foremost, is to reduce repeat maltreatment. Second, reduce maternal PTSD and depression symptoms. And one of the things we want to know is how much do we reduce it? You know, many people say, hey, I've got a significant effect, but was it clinically significant? Right? Did it make a difference in their lives? Did it reduce their impairment? And then we wanted to do something that's very rarely done, and it's truly one of the strengths of PCIT, which is to observe, to reduce negative parenting based on observation. Not, oh, I'm doing better with my kid, I'm so nice to my kid. I want to see what you're really doing. And that's a major PCIT contribution, right? Show me, don't tell me. You know, you could call it the Missouri therapy, right? The Kansas City therapy. So, and then one of the things we thought would happen is that we would reduce kids' symptoms. But lo and behold, we discovered something. We were not reducing kids' symptoms. And we kept scratching our head. And what we realized is that unlike Dr. Urquiza and you folks, our people were not coming based on kids having symptoms. They were based on mothers having symptoms, but about 35% of them do have a clinical level of symptoms. And when we look at that group, they do get better. Okay? So that was an important thing. And finally, we want to see what's making a difference. Is it emotion regulation, maybe? That when you increase emotion regulation, that predicts, is that the mechanism by which people get better? So let me tell you a little bit about our open trial. We've treated about 70 people. The clients tend to be poor. So about 32% of them are African American. About 60% of them are Hispanic. There are only 4.3 that are married, and 82% are single parents. And all of them meet diagnostic criteria using structured clinical interviews, the gold standard for PTSD and depression. 86% of the women we treat have both PTSD and depression. It's a big burden, right? And on the average, they have had 5 different types of trauma. Most experienced domestic violence when they were kids, and most experienced it as adults. And sexual abuse, physical abuse, and domestic violence, all 3 were exposed by about 42%. Now, what's interesting about this population, and I ask you to think about your own population, what's interesting about this population is we think about post-traumatic stress disorder. About 20% of the folks we treat have a new major trauma in their lives. Okay? Somebody beats them up again. We have one family where the 2 kids and the mom watch 3 men get shot in front of them. I mean, so these are really ongoing events. So it's very hard to reset the system if it's being triggered all the time, right? And mean mother's age is about 30. The kids 4 years old, and most of them make less than $10,000 a year. How many of you have been to New York? Let me tell you, ain't easy to live in New York for $10,000. You know, you think that LA is expensive. You know, and about 1/3 of the folks we treat are currently homeless and living in domestic violence shelters. So these are not cream puffs from the country club, right? These are women that it's very hard to get into treatment. We retain about 77% of, almost 80% of the women that we treat. But there's a secret to that. If you ask me later, I'll tell you. Now, let's talk a little bit about our primary aim and what we found. Keep in mind, this is not a randomized control trial. It was really tooth-breaking to even be able to start an open trial. And that's what I was referring to when I said I couldn't believe that they kept funding us, because our first year and a half, we had maybe 4 people in treatment. It was really tough, right? And so we compared repeat maltreatment over 6 months period for about 72 cases. And we compared the number of times they got reported again compared to the corresponding population across the whole city. And what we found is that 8.3% of our participants had new ACS reports. They had repeat maltreatment. And that compared to 32% for the overall population. Now, if you look at confirmed reports, do you guys have the distinction here? Confirmed report being defined by somebody calls, somebody goes out, checks it out, says, yeah, there's abuse. If we look at confirmed report, the rate for the overall population in New York is 18.6%. Our rate was 2.7%. That's pretty dramatic, right? Needs to be confirmed. But just by way of comparison, Chafin found that 19% of the clients who were receiving the motivational intervention with PTSD had repeat child maltreatment compared to 49%. And you can see these numbers. So the next question we had was, can we reduce maternal PTSD and depression symptoms like we hoped we could, right? That was one of our treatment goals that I outlined. And as you can see, if you look at the CAPS, the clinician-administered PTSD scale, the gold standard for PTSD, on average, they start out with 61 as a score, and they end up with about half. And the effect size, which is a measure of how much difference it made, is pretty substantial at 1.7. And you can see the same, but less powerful, happened with both the self-report measure of PTSD and the self-report measure of depression. So the next question, if you recall, was, does it make a difference? And one way to talk about whether it makes a difference is that when you diagnose somebody, do they still have the diagnosis? Now keep in mind that you can not have the diagnosis, but still have a lot of distress. And what we found is that 87% of our cases at post-treatment no longer met criteria for PTSD. That's pretty damn good, right? And at follow-up, it was slightly better. Now, my colleague, Marilyn Cloyster, did a very large study that was published in American Journal of Psychiatry. it's really of stare. And what she found is corresponding rates for the conditions were 61%, which was the best one. That was stare and exposure. And the rest were 47 and 33%. So we're getting really good results with really difficult population. Now, there's another way to think about clinical significance, which is remission. And one popular way to talk about remission in PTSD is, do you have a score below 20 on the CAPS? We can look and see what's the percentage of women that had a score below 20. And in our study, at post-treatment, about 40% of the women had a score below 20, and at follow-up, 38% versus 39%. If you look at the corresponding remission score rates for Cloyter's big study, 27% and 24%. So we're getting really substantial results in a 23-session treatment. So what about negative parenting and positive parenting? Mark Chafin did a beautiful study examining what was the predictor of PCIT success. And he found that the really big deal is the reduction of negative parenting. Right? And see, if you see here, we have pretty substantial reduction, about 50% less, right? Half. And pretty substantial increase in positive parenting, based, of course, on the DPICs. Now, yeah, so there it is. Sorry. That's we've all become, what do you call it? A PowerPoint addicts, and sometimes a syringe. So this just shows you that we have substantial reduction and significant reduction in clinical symptoms among those children who met the criteria for a clinical level of significance. And then we looked at a couple of other things. We were interested in, this number is no longer correct, by the way, because we have more people, but we were interested in this idea that after treatment, some people would be low in PTSD and low in depression, right? Some people would have a mixed result, and some people would be high in both. And what we found out is that, and we wanted to know what's the relationship between an improvement on PTSD and depression and an improvement in parenting outcomes. And what we found is that those people who had low PTSD and low depression post-treatment had a 67% in negative parenting score compared to 19% for the folks who didn't get at the same level of result. Remember, these are relative results. Everybody got better, but what we're setting is a half that got better. If you came out in the lower half of the group, then you were low, but if you were in the higher half, you were high. You see, so we just split them at the median. So what that suggests is, to the extent that you have good impact on PTSD and depression, you have much more substantial impact in change of parenting. We also looked at this whole notion of emotional regulation and maltreatment. And one widely used measure, although I don't like it because it has so much social desirability. People don't want to tell you how much they abuse their kids, right? Self-report, especially if they're already child welfare cases. But nevertheless, we took it as a proxy for the tendency to maltreat their kid. And what we found is the mothers who showed the greatest improvement in emotional regulation also showed the greatest reduction in maltreatment behavior, right? So for the people who had the best improvement in emotional regulation, they had substantially less impact. Okay, so this is just to remind us of what one of our colleagues mentioned, that at the end of the day, part of what we're doing is we're clearing away the impact of all these years of hurt. And that when you do that, we believe that there's going to be more resilience, in part because we're teaching people to manage the things that essentially disable them. And what's cute about this guy is he looks like a sumo wrestler, but we know that because he has somebody in his corner, right? So what are the implications for us? Then I'll be quiet because I'll give us 3 or 4 minutes for questions. I think there are a couple of implications. One is that it's really important as therapists to learn to see beyond the perpetrator imagery. When kids misbehave, we tend to make negative attributions about them. When parents can't function well, we tend to make negative attributions about them without seeing beyond that. I'm not saying don't be realistic. I'm saying that one of the really cool things about working with traumatized folks is you get to look for what's the best in them, for what they're doing right, and to hold up, sometimes for the first time, a mirror to what they're doing right. And very often, these are people who have never had a positive mirror. They've never had narcissism boosted in the normal course of life. And to the extent, and this will maybe embarrass you guys, but the nice thing about trauma work is you can be really nice. You can actually love people a little bit. Don't go overboard now. But, that's really the motion that makes it happen, is seeing the good thing in them. And what tends to happen is a parallel process where as you see the best in them, they become more able to see the best in their kids, right? So it's a parallel process, and you start to get really amazing stories and really amazing recovery. I didn't get into it, but a lot of these women now are getting jobs, going to school. There's a lot of sort of functional impairment that's being reduced. The other piece about recognizing trauma, and probably one of the reasons we as therapists protect ourselves, it makes us feel vulnerable, right? And it makes us feel overwhelmed. We do have, as therapists, the voyeuristic side. We kind of like that awful stuff. But we don't like to engage with it in a sustained, connected way. And because it creates secondary trauma, and it makes us feel disabled. So I think to recognize that as a way to protect yourself will make it easier to form an alliance. Okay? And the final thing I would say, and then I'll take a couple questions if I'm allowed, is that I invite you to look around. Because one of the dangers when you work with traumatized folks is just like they do, you can feel profoundly alone and disempowered. And people hate helplessness. Right? So I invite you to look around. Please look at each other. And the reason I invite you to look at each other is that I would like you to take home a sense that you really are, and this is a little embarrassing, I'm kind of not that kind of guy, but you really are doing God's work. And when you feel alone, I want you to remember that we're not alone in doing it. That there are other people who have the courage to engage. And the good news is you don't have to be perfect. You just have to be stupidly persistent. Thank you very much. So let me again thank Dr. Okiza and Timmer and the folks, including Lindsay Ford, who did a lot of the work behind the scenes to give us this chance to be together. And do I have the time to ask for a question? Yep. Any questions? Any comments? Thank you very much.
You now know why I rarely have a short conversation with Claude Chemtob. So I thank you very much. And also, just about every time I have a conversation with him, I'll walk away with a whole lot more thoughts in my head than I did before I had talked with him. So I thank you very much for sharing that information. We will now take a break. I think it's 15 minutes. We're a little bit behind, so why don't we... 10 minutes, she says. So 10 minutes after? 10 after the hour. Okay, and Feel free when you come back to fill in the chairs. There's lots of seats up to the front.